Hello, everyone, and welcome to our presentation on screening practices for non-viral STIs for patients with a diagnosis of vaginitis. I'd like to take a second to thank my research team because without them, this research would never have gotten completed. So a little background first. We all know that the three most common causes of vaginitis are trichomoniasis, bacterial vaginosis, and vulvovaginal candidiasis. The best way to diagnose these is by using the Nugent score, which requires gram staining, which most of us don't have in our clinical practice. So most of us rely on using AMSL criteria, which again is limited by A, our clinical experience, and B, what we have in our clinical practice, and C, time. And finally, the number one thing we like to remind people of is the recommendation for non-viral STI screening among patients who have a diagnosis of vaginitis, specifically trich or BV. Although in candidiasis, we also recommend it in patients with risk factors. So for our methods, we use IVM market scan data from 2012 to 2017. We use only women. We excluded women below 18 and above 50, women with a history of HIV, cancer, and pregnancy to limit our bias within the study and to limit our chances of finding other causes for vaginitis. We also used the following CPT codes listed down here for microscopy, DNA probe, NAT, and chlamydia and gonorrhea testing to pull the data from market scan. It's important to note that any woman that was enrolled in market scan had to have been enrolled for at least a year prior to this vaginitis case. So we were calling that our incident or index vaginitis case. So of those patients who had an index vaginitis case, 1.35 million were enrolled and we were able to include them in the study. Of those, 49% did not undergo any diagnostic testing for vaginitis at all. And even more concerning is among those who didn't have any diagnostic vaginitis testing, they did have only 23% underwent STI screening. For traditional, those who underwent wet pret testing, which made up 26% of the whole sample, about 35% underwent chlamydia and gonorrhea testing. And then you can see here the DNA and the NAT testing, so our molecular diagnostic test, where more patients underwent chlamydia and gonorrhea testing. And then we have this other group, which is patients who had partial codes or a combination of tests, and it's only 3% of the population. And even though they had 62%, it's hard to ascertain what that actually tells us. So our big conclusions and takeaways is the goal to adhere to the guidelines. So we want to adhere to using microscopy. And if we can't, or there's reasons, or we're transitioning to telemedicine, perhaps we really need to visit why we're doing this and other alternative methodologies. Because NAT and PCR are really very reliable. They're just as good as Nugent testing, if not better, and they are better than AMSL testing when compared head to head. Additionally, NATs, when used, seem to have shown that there's an increase in STI screening, and this may just be because they're bundled. But again, if they're bundled and that improves STI screening, this is really doing us a service for women's health practitioners. And finally, increasing STI screening is very, very important for women's health, not just women of all ages, but specifically those who are of childbearing age or who are meeting criteria to be screened because they're under the age of 25 and sexually active. So thank you so much for your time.